welcome to the third class in this internal medicine series. So today we're looking at heart wall diseases, especially pericardial and endocardial diseases. Myocardial diseases will be in another lesson. Um, to, to give a very brief overview, the heart's function depends on how well the walls and its linings work. The heart wall diseases affect the outer pericardium, the middle myocardium, and the inner endocardium. The middle myocardium, as I said, we'll speak in a different lesson, but these two are they go hand in hand. So it's a good way to quite simple to understand these two things together. So there's a very large clinical implication to these diseases. So we could have very mild inflammation of this heart wall. So, for example, with pericarditis, or you can have life-threatening complications like cardiac tamponade. The focus, as I said today, will be for pericardial diseases and endocardial diseases. And within pericardial diseases, we will look at inflammation, effusions, tamponades, constrictive pericardial diseases. And endocardial diseases will look at valvular infections and certain and other types of infections as well. And we'll also have a very quick look at myxomas, atrial myxoma or tumor. So a brief overview about the heart wall. So as I said, we have the pericardium, myocardium, and endocardium going from out to in. Endocardium being the innermost. Now, the pericardium is a fibrous and it's composed of fibrous and serous layers, and it lubricates the heart with about 20 to 49 milliliters of fluid. Right, so it reduces the friction that the heart has inside this sac. So the pericardium has a protective function, and it stops the heart from overdilating. What it kind of does to the heart is that it stops it from exploding, essentially. It is what controls the equilibrium between the two ventricles, so how well the two ventricles will actually dilate. So this is what it controls. Now the myocardium is the muscular middle layer. All you need to know for this class is that it generates the force required for blood to be pumped throughout the body. The endocardium, which we have spoken about a little bit in the last class about valvular diseases, but essentially what endocardium is that it's a lining of the chambers and valves, and it prevents blood clots from forming. So it provides a smooth, frictionless surface for blood flow, and it prevents blood from sticking to the heart and coagulating within the heart and forming clots. So, as I said, very brief overview. Now, let's look at the pericardium first. So the pericardium has two layers, right? It has the inner visceral pericardium, which is what the pericardium attaches on the myocardium. And it has the outer parietal pericardium, which is contiguous with the inner layer. Now, what the pericardium is that it is a fibrous serous sac, and it just covers the surface of the heart. This pericardium is important because pericardium provides that protective sac that the heart can sit inside. Within the middle mediastinum, where the heart is situated, it is connected to the sternum through the sternopericardial ligament. So it has a couple of functions, but these are the important things for this particular class. So inner visceral pericardium, outer parietal pericardium. Now, the inner visceral pericardium has it has a microvillous surface that secretes pericardial fluid. Now, this fluid is very important because it allows the heart to kind of move within that space in a frictionless way. And it also allows the heart to dilate freely as well. So this is the kind of function of it. Now, the outer layer, the parietal pericardium, it gives the kind of the structural role that the pericardium plays. As I said earlier, what the pericardium stops the heart from doing is dilating so much that it bursts. So the outer pericardium will have what it does is that it's composed of collagen layers and interspersed elastin fibrils, and the layering of this kind of provide that elastic effect, that recoil effect that is really important to create pressures inside the heart to help with pumping blood out into, say, the systemic or the pulmonary circulations. Now, the pericardium is perfused by the internal mammary arteries, and it's innervated by the phrenic nerve. Now, the internal mammary arteries becomes quite important in surgeries like coronary artery bypass grafts, and and it's quite important also to keep the fact that it is innervated by the phrenic nerve in your mind for the next few slides. Okay, I will explain more in a bit. So as I said, the function is really to protect and restrain the heart, so stops the heart from filling up too much and blowing up. And it also determines cardiac filling patterns. In other words, how much blood that goes into the goes into the chamber, and it limits chamber dilation. Right. So let's look into pericardial diseases. So some of the major pericardial disorders that you need to know are acute and relapsing pericarditis. That this is kind of bunched together in acute pericarditis, but what it is simply just the inflammation of the pericardium. And constrictive pericarditis. So this is also within chronic pericarditis. So it is a subtype of chronic pericarditis. And this is actually talking more about fibrosis and thickening of the pericardium, which impairs the filling or the dilation of the chamber, and therefore causes problems for us down the line. Okay. Then we have pericardial effusion. Pericardial effusion can be a clinical emergency, but by and large, it's not. It is literally just the fluid, the accumulation of pericardial fluid in the pericardial sac. So this fluid can be serous or seroanguinous. So seroanguinous means serous and blood inside. So pericardial effusion can be seen in situations like that. And cardiac tamponade. So cardiac tamponade is a clinical emergency. And it is what it does is that there's so much fluid around the pericardial space that it compresses the heart and stops the heart from actually pumping out, filling properly, and thereby pumping blood out properly. So we will look into that in a bit. But I've written a very small note at the end of this slide. So how does it do this? So your normal pericardium, it actually, there is transmission of water and electrolytes and pericardial fluid with the serum of the blood, right? Now, in inflamed pericardial tissue impairs that equilibrium, and if the equilibrium is impaired, then you have an increased transmission of fluid into the pericardial sac, and this can be serous or seroanguinous. So serous fluid, seroanguinous, serum, and so like serous fluid and blood. So it's this kind of impairment of the equilibrium is what actually causes buildup of fluid, and this buildup of fluid can cause your complications, your pericardial disorders. Right, so we'll look at acute pericarditis. Now, What you need to know about acute pericarditis is that it is defined as new onset inflammation lasting less than 4 weeks up to 6 weeks. Now, it is clinically characterized by a triad of chest pain, of positional changes in the physical exam, and also echographic changes. So when you do an echo, you can see it quite well. You can detect a pericardial effusion. Now, pericarditis is the most common disease of the pericardium encountered in clinical practice. So when we look at the pathophysiology, literally all that happens is that we have pericardial inflammation, which is triggered by an immune response. So you have that impairment of the equilibrium that I spoke about, which increases the vascular permeability. So fluid leaks into the pericardium. Is that we have pericardial inflammation, which is triggered by an immune response. So you have that impairment of the equilibrium that I spoke about, which increases the vascular permeability. So fluid leaks into the pericardial space, causing an effusion. Then you have fibrin deposition on pericardial surfaces, which then creates like a kind of barrier, a fluid inside that increases the friction between the layers. And this friction between the layers is what we hear on auscultation, and we call this the pericardial rub. Now, in terms of symptoms, the symptoms of pericarditis is a very sharp, severe retrosternal or central sternal chest pain, and it worsens on inspiration and a supine position. So pain that increases on inspiration is called a pleuritic pain, and as I said, this pain is generally is worse when that patient is standing up. Now, this pain, if you remember from what I said a little bit earlier, is due to the fact that the pericardium is well innervated by the phrenic nerve. Now, this innervation is what causes that very sharp, sharp pain. Now, the risk factors of somebody getting pericarditis mainly tend to be, for example, being of male sex. Patients who are between the ages of 20 and 50, they're more likely to get pericarditis. Anybody who's had a transmural myocardial infarction, so that transmural literally means between wall MI. So you can have you can have two forms of pericarditis following an MI. You can have early pericarditis, which is also called pericarditis epistenocardica. And you can also have something called Dressler's syndrome. So Dressler's syndrome is delayed pericarditis post-MI. So that's one of the complications or risks of having an MI. I've talked about uremia as well. So uremia, when we have lots of, acid buildup, uric acid buildup in the blood. This can actually cause pericardial effusions and go on to cause pericarditis. Obviously your bacterial, TB, fungal. So when we look at the kind of infective causes of pericarditis, mainly it's viral pericarditis that a patient comes in with, and this this inflammation is due to direct viral attack or an immune response. So this immune response can be antiviral or anti-cardiac responses, but what it kind of results in is acute pericarditis. Now, for your high yield marks, what you need to know is that viral pericarditis, the most common kind of causes of it are Coxsackie B virus, excuse me, Epstein-Barr virus, cytomegalovirus, varicella, rubella, and of course, our favorite, SARS-CoV. So COVID. One of the key, so when a patient comes in and you do your physical exam, you hear this kind of pericardial friction rub, you know that they have a very sharp centrosternal chest pain, and they're feverish and they're malaised. Something that you need to actually think about is, you know what, maybe I should do a COVID test, maybe I should do a influenza screen, maybe I should do a respiratory panel. So these are all tests to find out if that person has a viral infection. And with other investigations, such as your chest X-ray, we can see possibly an enlarged heart with an effusion. This may kind of influence our treatment options. In terms of your ECG, what you actually see is you see diffuse ST elevations, but they won't be as high as what we see in STEMIs. So ST elevation, myocardial infarctions. Alongside these ST elevations, what we will see is PR depressions. One of the easiest ways to see if a patient is having acute pericarditis or not from the ECG is looking at the V5 lead and comparing the traces. So what you will see in the V5 is you will see PR depression and ST elevation, and then you have to look at the reciprocal lead, which is AVR. And there you will see a PR elevation and an ST depression in AVR. So if there are reciprocal changes, then you can be a bit more confident from your diagnosis from the ECG itself that this patient might have acute pericarditis. And finally, my favorite test of all, echo. So an echo is fantastic at detecting pericardial effusion, and nowadays, especially when a patient is coming in with acute chest pain, say in the emergency department, something that we can do is point of care ultrasounding. So we can actually ultrasound the heart straight away, and you can find out if that person has a pericardial effusion or not, simply by doing the ultrasound. Now, in terms of treatment, it's actually fairly bog standard. So treatment-wise, the way you treat a patient with acute pericarditis is using non-steroidal anti-inflammatories. So this is for the pain and the inflammation. So a couple of examples include aspirin, and another one is ibuprofen. By and large, this is what we give to patients. Another one that you can give is naproxen. Now, the other kind of medication that we give in this case is colchicine. So colchicine is crucial because what it does is that it prevents recurrent pericarditis, and it improves the response to treatment through, say, non-steroidal anti-inflammatories. And how does it work? It works by reducing uric acid in the body. So it's very good. It's actually a gout treatment. It stops the buildup of uric acid crystals. But it's a very, very good treatment that you can give in acute pericarditis. Now, so I want to also just talk to you about a couple more things that you need to know about acute pericarditis that's not really in the slide. We have various kind of levels of pericarditis that we need to know. So as I said, acute pericarditis is new onset, less than 4 to 6 weeks. In terms of symptoms, less than 4 to 6 weeks, and Generally, you need four things to diagnose somebody with acute pericarditis. So that characteristic chest pain, very sharp, retrosternal, pleuritic pain, relieved by sitting forwards or worsened by lying flat. The pericardial friction rub. So it's kind of like walking through very crunchy snow, right? So when you listen, when you auscultate the patient, you may be able to hear a pericardial friction rub, and it's kind of like crunchy snow. Um, and from the ECG, new widespread diffuse concave saddle-shaped ST elevations or PR depressions on the ECG. Finally, from your other investigations like echo, etc., you can see a new or worsening pericardial effusion. Now, after acute pericarditis, something that we have is something called incessant pericarditis. So it lasts a little bit more than 4 weeks, but it will terminate before 3 months, and without happening again. So that's very key, because if it happens again, this is called recurrent pericarditis. So recurrent pericarditis is essentially the recurrence of the signs and symptoms that we've spoken about after one episode of acute pericarditis. This recurrent pericarditis is kind of has the same kind of timeline as acute pericarditis, because it should technically terminate before 4 to 6 weeks, but it doesn't have to. It's not like characteristic, because the patient can have another episode of pericarditis again, and this will be categorized as recurrent pericarditis. And finally, if you have pericarditis quite a few times and you have the symptoms last more than 3 months, you have something called chronic pericarditis. And within chronic pericarditis, we have subtypes that I mentioned earlier: constrictive pericarditis, which is what we will look at, and that is due to chronically thickened pericardium. And you also have effusive constrictive. So this is with effusion. You have a chronic effusion inside, plus you have constrictive changes. And also adhesive. So that's adhesive is just like layers kind of stuck together, but it doesn't constrict. It just doesn't work as it should. Okay. So I just want to also, one more thing about pericarditis is what you should do when a patient comes in with pericarditis, when you do a physical examination. I told you that you have the pericardial friction rub. The pericardial friction rub is kind of like crunchy snow. Basically, this friction rub is heard best at the left sternal edge, and and the best way to really listen or hear this is to ask the patient to hold their breath, and when they hold their breath, the subsequent heartbeat will actually give off that sound, that crunchy sound, and it will kind of give you a idea. Okay, should I suspect this patient has pericarditis or not? Okay. Let's move on to constrictive pericarditis. So I know that was quite long-winded, but there's a method to the madness. Now, constrictive pericarditis is a form of chronic pericarditis. So essentially, with constrictive pericarditis, what you have is chronic pericardial inflammation lasting more than 3 months. We have fibrosis and calcification of the pericardium, which causes the pericardium to become stiff and non-compliant. And what that does is that it impairs the diastolic filling of the heart, and therefore it reduces the cardiac output. If you have reduced cardiac output, what happens is that there's less oxygen reaching tissues according to the metabolic demand of the tissue. So this increases the chance that we can go into shock, and increases the chance of going into say multiple organ failure or even death. So so this is why constrictive pericarditis can actually be quite dangerous. Now, how do we find out if this patient has constrictive pericarditis or not? Um, so constrictive pericarditis, this patient will have peripheral edema, ascites, because what they will have is symptoms of heart failure. There is so much force, there's so much uh, pressure build up because of the way the pericardium has now become stiff and non-compliant, that the heart also goes through remodeling, and this remodeling causes increases in the central venous pressure, and therefore you have an increase in the intravascular pressure, and lots of fluid will leak out into third spaces, especially in, say, the ankle, the legs, and inside the abdomen as well. And this results in peripheral edema, ascites. We also have the Kussmaul sign. So the Kussmaul sign is a rise in the jugular venous pressure on inspiration. How do you examine this? So you ask the patient to look to the left or to the right, depending on where you are, and you have a look at the jugular vein. Now you see if that vein is distended or not when and by after you ask the patient to take a deep breath. And if the jugular vein increases in size on inspiration, this patient has a positive Kussmaul sign, and it's a sign of constrictive pericarditis. And the other thing with constrictive pericarditis is that these patients will come in with fatigue and exercise intolerance. Now, the thing with fatigue and exercise intolerance is that it's a sign that the heart is not able to give enough cardiac output to meet the metabolic demand of the body. And I think it's a fairly non-specific symptom, but it is specific to say that, oh, you know what, the heart isn't actually working as well as it should be. Now, how do we find out if somebody has constrictive pericarditis or not? Once again, echo is very accessible, very easy way to have a look at that. So what you'll see is thickened pericardium. You may see some calcifications from the image as well. And what you generally are looking for is you're trying to see if the patient's heart is filling properly or not. Now, if there is impaired filling, then this increases the suspicion that this patient might have chronic pericarditis or constrictive pericarditis. We can do CT or MRI. So what this will show is, again, calcification and pericardial wall thickening. And we can also do cardiac catheterizations. So if your center, if your hospital has an ability to do that, it's okay, but it's not as accessible as an echo, and certainly and also CTs and certainly MRIs. So I personally would refer this patient to an echo. And then if the echo is inconclusive, only would I then go for a CT or MRI, and if that is inconclusive, then I'll think about a cardiac cath. But I wouldn't often do it. Now, what are the causes? So chronic pericarditis can happen because of post-cardiac surgery changes. So obviously, when you do a stenotomy, when you do an open heart surgery, you're going to cut through the pericardium to get into the heart. So scar tissue formation, there'll be fibrosis, there'll be and over time some calcification of the pericardium, and this can create a stiff and non-compliant sac. So that's one way you can have that. Another way is things like infection. So TB is another is one of those things that causes this. but infections or long-term constant chronic infections and radiotherapy as well. So radiotherapy can kill the cells that make up the pericardium, and it can also damage the function of the pericardium, and therefore cause constrictive or chronic changes to the structure of the pericardium. Right. Now, if it is, so what we can do for patients with chronic pericarditis is that we can do a pericardectomy, and that is the surgical removal of the pericardium. But by and large, we only really do this if that patient is really under risk of getting a cardiac tamponade. Or their effusion is genuine, it's just too much, it just happens too often for us not to address this problem. So surgical removal of the pericardium is something that we can do. But mainly what we can do is we can give diuretics. So diuretics make sure that these patients are able to, remove the excess fluid from these spaces, from the pericardium, etc. And this is the best way to really manage chronic pericarditis. Now, I also want to mention that, oh, excuse me. So with these patients, remember, diuretics is one thing that you can give. Another thing you can actually give is when they have flare-ups, you can give non-steroidal anti-inflammatories. So again, aspirin and ibuprofen. We can also, we generally tend to give colchicine as well. As a long-term therapy to make sure that these patients kind of have a better response to treatment. Now, I just want to also just speak about pericardial effusions and cardiac tamponades. So effusion is a buildup of fluid within the pericardial space. And what happens is that the effusion or a buildup of fluid will increase the intrapericardial pressure, and therefore it reduces ventricular filling during diastole. This reduces the stroke volume, or the volume of blood that is released at every systole, every contraction of the heart, and it therefore reduces cardiac output. Now, what can happen is that this can cause hypotension because not enough blood is being pumped around the body, and this patient can go into shock. So this is what we see in an extreme circumstance, is what we see in cardiac tamponade. So, in cardiac tamponade, what happens is that cardiac output is so low that there is simply not enough oxygen reaching the tissues according to its metabolic demand. So this patient can go into shock, and this patient can therefore go and die. Now, when we suspect somebody's coming in with pericardial effusion, what we should really do again is get echocardiography. So that's again the best test. But in the emergency room, the easiest way to find out if a patient has an effusion or not is through chest X-rays. So we look for the water bottle shaped heart. So the bottom of the heart, that shadow will be much bigger than the top. So it looks like a wine bottle. But that's upon your interpretation. Now, in ECG is also very accessible, and we will see very kind of small QRS complexes because the ventricle. So QRS complexes are showing you ventricular systole. Now, what low voltage QRS literally just means small ventricular, QRS complex, very small in comparison to normal, and it just shows that the heart is not, like, the systolic pressure is not enough. It's quite weak, and I've also written pericardiocentesis, but to be honest, pericardiocentesis is done in a diagnostic sense and a therapeutic sense. Um, but before we go into pericardiocentesis, one of the best ways to actually we need to kind of grade the effusion, and if the effusion is a minor effusion, diuretics should be enough. But if it is not, and it is treatment resistant, then it is a good idea to stick a just form a pericardial tap and then drain that fluid. And in a cardiac tamponade, there's no question. We're going to do emergency pericardiocentesis. Now, clinical features. I believe I have a picture about this, but yes. With cardiac tamponade, what you need to know is the Beck's triad. So there's a nice picture here. Beck's triad is essentially, you see jugular venous distension. So we have as I said, how do you test this? You ask the patient to turn their neck to the side, look at the jugular vein, and see if it is distended or not. It is, and especially if you ask them to take a very deep breath, this will also increase in size. The other part of this triad is hypotension, and finally muffled heart sounds. So there's so much fluid inside the pericardium that when we try to listen to the heart in the various auscultation points, the sound is actually quite dull. Oops. Yeah. So this is cardiac tamponade, and cardiac tamponade's major features. We can also have other signs such as pulsus paradoxus. So pulsus paradoxus is essentially the volumes within the left heart will be decreased with inspiration, and this results in exaggerated decrease in the systemic cardiac output and a drop in the systemic blood pressure. So clinically, when there is a drop of more than 10 millimeters mercury let me start again. If there is a drop of systemic blood pressure more than 10 millimeters mercury with inspiration, this is what we call pulsus paradoxus. Another one is tachycardia. So because the heart is not able to keep up the cardiac output that is required to meet the metabolic demand of the tissues, the heart increases its speed, its heart rate, in an effort to just bring out more blood and push more blood into the systemic circulation. And shortness of breath is another sign that we see. So I showed you the Beck's triad already. Now, this picture here on the left-hand side just shows what we do for pericardiocentesis. Now, of course, we have the sternum to think about and the ribs to think about when it comes to access into the heart. Nowadays, what we use to aid in pericardiocentesis is ultrasound. So you can use an ultrasound probe to find out, find the point, find the pericardial sac with the effusion inside, and you can then use your needle to then guide your way into the pericardial sac in a stepwise manner. So this is one of the ways that it's done now, and you can drain the fluid. And save that person from an effusion. To be honest, the way we do that is just through a pericardial window. So we put a wire in, and then we will have a tap that we can open to drain that fluid, and we can close it as well. Now, let's also talk, let's go on to talk about endocardial diseases. So, when we look at endocardial diseases, the most important one is infective endocarditis. This is the one we encounter in clinical practice more, and there are bacterial kind of risk factors from it, or fungal. As mainly the key word here is vegetations. So they're like small balls of kind of like small leaves, small fragments of leaves that can then get deposited in damaged areas of the endocardium and become infected. Then we also have non-infective thrombotic endocarditis, which has sterile vegetations. We have valvular damage, because remember, valves are lined with endocardium. So this could be from rheumatic heart disease or calcific changes of the heart. We can have congenital abnormalities within the endocardium, so endocardial cushion abnormalities, and also primary tumors, so atrial myxomas. Now, infective endocarditis is what we're going to really focus on. So typically, what we see in infective endocarditis is bacterial or fungal kind of infections that occur and that go on to cause endocarditis. The most common pathogen that causes this, and the one that you need to know the most, is Staphylococcus aureus. Okay, we can also get it from Viridans group streptococci, especially if that patient has implants like a pacemaker, stuff like that. And intravenous drug users who are at very high risk of contracting infective endocarditis. And this is because they're more likely to have Staphylococcus aureus. And also be in mind people who have prosthetic heart valves can also get infective endocarditis, especially, so of course Staphylococcus aureus, but other ones are enterococci as well. Now, patients who are immunosuppressed are far more likely to have to get infective endocarditis. Just being in mind that if they're immunosuppressed, we have to be far more careful with them, because and they're more likely to have a very funky type of infection as well, like a very rare kind of pathogens could actually affect them. Okay, so infective endocarditis typically develops on the valvular surface of the heart. Okay, valvular surface of the heart, which have sustained endothelial damage secondary to turbulent blood flow, are the most likeliest areas where where these vegetations can actually go and deposit or get bigger. All right. Now, what tends to happen is that we can have sustained endothelial damage caused by turbulent blood flow. And as a result, platelets and fibrin will adhere to the underlying surface and create an area that promotes thrombosis. It promotes kind of the formation of vegetation, promotes the formation of clots. Okay, so this is because of that damaged area. What the heart is trying to do, or what the immune system is trying to do, is it's trying to promote the repair of that area, and it does so by getting platelets and fibrin to concentrate on that area. And what it therefore does is that it creates a particular localization or particular area where clots are more likely to form as a result. Now, if, for example, this patient has say, an infection, a bacteremia, let's say, what can happen is that the bacteria within the blood, well, inevitably this bacteria will reach the heart, right? Because all blood is going to be processed through the heart anyway. So bacteremic colonization can create these thrombi, or these kind of what we call vegetations bacterial products plus fibrin plus platelets, and it traps the organisms. So this is what we call a vegetation. So like bacterial organism plus fibrin plus platelets is what we call vegetation. Now, without the bacteria, fibrin and platelet sticking together will give you a sterile thrombus. That's another type of endocarditis. But the infective type, what's important is that we have vegetation that is fibrin plus platelet plus organism. It could be bacterial or fungal, whatever. Now, what can then go on to happen is that this vegetation can get bigger and bigger and bigger. And what can then happen is that there can be, because obviously we have a bacterial organism in, that is deposited there and it's multiplying, we can have an inflammatory response that is created against that organism. Now, the release of these powerful chemicals can then cause the destruction of the valve, and that can go on to cause regurgitation, heart failure, things like that. Now, what's scarier than that is this vegetation can actually just pop off from the from that area, and it can then be transmitted all across the body, and it can then cause infarcts where it causes a complete block of the blood vessel, or it could cause something really bad like a stroke, especially if that patient has AF. So just remember, when you have a think about it later, just remember the key things here is that we have a damage to the endocardium through turbulent blood flow. We have a localized area where we have more platelets and fibrin. So that damaged area will promote fibrin and platelets to arrive, and it creates a prothrombotic region. And if that patient also has a systemic bacteremia or a bacterial infection in the bloodstream, fibrin plus platelet plus organism creates a vegetation. Now that vegetation can pop off, and then it can cause the formation of an emboli that can then go on to cause infarcts or systemic complications. Now, what I have not written here is what we call this turbulent blood flow. So especially in it's not really used much anymore, but what they're called is jet lesions. It's essentially a jet of blood because of valvular changes, because of pressure related changes. You have a jet of blood that comes at a very high pressure, and it will go and damage the endocardium, right? And it will form like small cuts, that then will cause the formation of these vegetations. Now, when we look at the clinical classification of infective endocarditis, remember it can be acute or subacute. Now, acute typically develops over a period of days to weeks, and it will give you all the constitutional symptoms like fevers, fatigue, and alongside it, related to the heart, we have tachycardia, and also progressive damage to the valve, especially. Okay, so you can have a murmur as a result. So it can be a systolic murmur or a diastolic murmur, and this is because of progressive damage to the cardiac structures. Subacute is a situation where it develops over the course of weeks to months, and these patients will often complain of very vague kind of constitutional symptoms. So they'll say, I've just been feeling feverish every now and then, and it's just not, it hasn't gone away. I feel very fatigued. And when you put your stethoscope on their heart, they have a murmur. And this is where we have to then look at peripheral signs like Osler nodes, Janeway lesions, cutaneous infarct, Roth spots. These are all things that we can look for in a patient, especially if they come in and they talk about vague symptoms like they do if they have subacute infective endocarditis. Okay. Now, investigations-wise, you need to send off a blood culture straight away. So you send off blood cultures if a patient is spiking temperatures. And you always do it before you give that patient antibiotics. You do, if you can, you do an echo, and if you can, you also try to give them antibiotics straight away. So the blood culture will give you the best course of antibiotic action, but something broad spectrum to start off would be good. Now, when to do surgery? Well, you do surgery if that patient's heart failure is driven by valvular destruction, and you do surgery, so especially thrombectomies, if the vegetation is larger than 10 millimeters. But to be honest, there are ways to ways to stop this from happening. So you can give this patient things like anticoagulants. Something as small as aspirin is enough to break down these clots. So this is a way to kind of help patients like this. Now, with infective endocarditis, the most important thing that you need to know for your exams is the Duke's criteria. Now, what you see in front of you is the Duke's criteria. So you have major criteria and minor criteria. Now, if you so in terms of major criteria, what we're actually looking for is positive blood cultures and evidence of myocardial involvement. So if the blood culture is positive and and you have endocardial involvement, in other words, a new murmur, evidence from your echo, any abscesses, things like that, then you can actually say, well, this patient, according to Duke criteria, has an infective endocarditis. In terms of minor criteria, if they have a fever, so fever is quite non-specific. So therefore, you need other things within the minor criteria to also say, okay, you know what? This patient might have infective endocarditis. So along with the fever, do they have, say, vascular phenomenon like an emboli, like a stroke, like sorry, not a stroke, I meant an evidence of an emboli. Do they have Janeway lesions? Do they have immunological phenomenon like Osler nodes or Roth spots? Are they likely to have infective endocarditis? So, for example, do they abuse intravenous drugs? And is there any microbiological evidence that does not meet the major criteria? So this criteria, this is used to diagnose infective endocarditis. So this is called the Dukes criteria, D-U-K-E-S criteria. Now, a couple of pictures of what we're talking about in terms of Osler nodes, Janeway lesions. So cutaneous infarcts are essentially infarcts within the skin. Osler nodes, you can see it in the nail beds, and they're kind of like these purpley splinter hemorrhages. You can see Janeway lesions in the feet and the hands. Roth spot is when you do a fundoscopy, you can see hemorrhages, small hemorrhages all over the eyes. And using your Duke's criteria, you can then diagnose this patient with infective endocarditis more readily. Now, something that I would recommend is for you guys to have a look at these particular clinical features and familiarize yourself with those pictures, because just from clinical examination, I have been able to diagnose someone with infective endocarditis within 1 hour of that patient presenting. And every second counts when it comes to a patient coming in with something like this, because they can become septic very quickly, and they can also, before you know it, they may also get something like a stroke. So it's very important to just familiarize, just have a look. Okay. Now, non-infective thrombotic endocarditis. So this is another form of endocarditis where you have endothelial injury as a result of, say, jet lesions, turbulent blood flow, things like that. It creates a local area where you have platelet and fibrin deposition, and this local area is therefore prothrombotic or hypercoagulable, and this can cause formation of sterile vegetations, and these sterile vegetations can kind of pop off from the area that it's stuck to, and cause infarcts in the brain, spleen, or kidneys. Now, once again, for reiteration, platelets plus fibrin plus a bacterial organism, that vegetation is what causes infective endocarditis. But when you take away the fact that that person does not have bacteremia, this is a sterile thrombus. Now, currently speaking, they mainly arise from embolic events like stroke. Stroke is the main one, to be honest. You can have splenic infarct. You can have kind of changes to the skin, changes to the nails, changes to the fingers, so you can have like splinter hemorrhages, things like that. But the thing is, this is quite hard to diagnose because you don't have the classical constitutional symptoms like fevers. And you may not even have murmurs, because what causes damage to the valves are the bacterial organisms within that vegetation. It is not platelet or fibrin. Now, in terms of investigations, blood cultures are still taken, but these are negative. And this is what the main difference between non-infective thrombotic endocarditis and infective endocarditis is. We can screen for underlying causes like systemic lupus erythematosus or malignancies. So what we want to do in patients who have this is to treat the underlying cause and give them anticoagulation to prevent embolization. But we don't need to routinely do anything invasive. We could just manage this as normal. Now, a couple of things to speak about when it comes to valvular endocardial disease. So we can have rheumatic heart disease and calcific degeneration. Now, rheumatic heart disease, I've spoken about it a little bit in the past in terms of valvular diseases, but rheumatic heart disease we'll call it's an autoimmune disease. So post-streptococcal pharyngitis will cause a molecular mimicry that triggers autoimmune reactions. And what this goes on to cause is chronic inflammation of valves. And the inflammation of those valves creates leaflet thickening and fibrosis. what you can then go on to have is commissural fusion, so the fusion of the valve leaflets and the chordae tendineae to shorten. This can lead to stenosis or regurgitation, but mostly mitral regurgitation is what rheumatic heart disease goes on to cause. Now, it often presents in young adults, especially in developing countries, and it presents years after initial infection. It can involve all the valves, but the main one is mitral, and the main key, like high yield point, is that it causes mitral regurgitation. We can also have calcific degeneration. Now, I've spoken about this in in the previous class. Calcific degeneration is especially prevalent in aortic stenosis. In terms of pathophysiology, patients who are quite old, who have chronic mechanical stress on their valves, go on to have progressive calcium deposition on their valve cusps. The leaflets will then stiffen and it impairs the opening, resulting in aortic stenosis. And if you have a valve area that's less than 1, we have to think about replacing that valve. So it's quite common in the elderly. Excuse me. It's quite common in the elderly. So especially if somebody has congenital problems with their aortic valve, this can happen at a faster rate. And classically, the symptoms are SAD, syncope, angina, and dyspnea. Okay. Oops. Now, let's talk about a primary tumor that can also happen in the endocardium. So atrial myxomas are a benign endocardial tumor, mostly in the left atrium, that can obstruct blood flow or go on to cause embolic phenomena. Now, this is a form of endocardial neoplasm, and it actually arises from the subendocardial mesenchyme. Now, it forms a mobile pedunculated atrial mass, and it's commonly near the fossa ovalis. And the intermittent obstruction of the mitral valve because it's mobile, remember, the obstruction of the mitral valve can reduce cardiac output, and it can cause embolization. So to occur, so blood clots can occur, and it can go on to cause things like stroke. Now, how do we find out if the patient has myxoma or not? So we can do echo. Of course, it's my favorite. It's the best test, best initial test, and we can easily visualize a mass. We can do CTs or a cardiac MRI if you have that facility. But CT should you should really be able to see it in a CT. And this is good for staging that tumor. So size, if it's attaching to something, does it have vascular infiltration as well, and how mobile it is. And we can, of course, do some blood tests for it as well. In terms of clinical features, mainly they're related with the obstruction. So the obstruction of the mitral valve. So syncope, shortness of breath, orthopnea, so shortness of breath while lying down. These are mainly the things that happen. You can also have embolic events, so strokes, ischemic limb, organ infarcts. So that's it's really bad to have that, but this is also something that could occur. And constitutional symptoms like fever, weight loss, fatigue. In terms of treatment, we can surgically excise this tumor, and because it's benign, it's quite there's a low risk of this reoccurring, and a recurrence is low, but what you can do for the patient is to surveil them and have yearly checkups. So yearly echo, especially, is recommended. So that's with atrial myxomas. Quite rare, but it's something to note. Now, conclusion. So these diseases, so heart wall diseases, can affect the outer uh, or inner layers, and with distinct pathophysiology. Uh, Recognizing these things early will prevent life-threatening complications, and echo is once again central for diagnosis in both groups. Now, let's do some questions. So what I would like you to do is I will stick these questions on the chat. I'm not going to pick on anyone. On the chat, if you can just guess, if you can just put your answers on, we'll, afterwards I'll show you the answer and then I'll explain it as well. Okay, so a 45-year-old man presents with fever, new onset cardiac murmur, and splinter hemorrhages. Which diagnosis is most likely? A, acute pericarditis. B, infective endocarditis. C, myocarditis. Or D, rheumatic fever. So let's have a quick look. Okay, only one answer. Goodness. So yeah, it's infective endocarditis. Why? Splinter hemorrhages, fever, and the new onset cardiac murmur, because the infective element or the bacterial organism will cause will be the reason why you have damage to the valve, which goes on to cause that murmur. A 28-year-old woman presents with pleuritic chest pain that improves when leaning forward. ECG shows widespread concave ST elevation and PR depression. Which investigation would be most useful to confirm suspected diagnosis? So coronary angiography, echocardiography, CT chest, troponin assay. I'm glad you guys are listening. It's my favorite. It's an echo. So echo is very, very good way to find out if there is. So this patient possibly has acute pericarditis. So an easy way to look for fluid within the pericardial sac would be to do an echo. You can do a bedside echo, or you can get an echo done formally as well. So echocardiography. Now, 65-year-old patient develops progressive dyspnea and peripheral edema. Echocardiogram shows a pericardial thickening uh, and a septal. I have no idea what happened there. But which condition is most likely? To quickly check. Oh, septal bounce. Don't worry, guys. That's it's constrictive pericarditis. Not sure what happened in terms of formatting there, but key word there is pericardial thickening. Now the thickening is indicative of fibrotic changes. This this is what gives rise to a septal bounce. But don't worry about that. A 32-year-old man presents with acute idiopathic pericarditis. According to ESC guidelines, what is the first line treatment? A, intravenous corticosteroids, B, aspirin or non-steroidal anti-inflammatories plus colchicine, C, antibiotics, or D, pericardiocentesis. You would have noticed a trend by now. Yeah, aspirin, non-steroidal anti-inflammatories, plus colchicine. So this is our first-line treatment, and we reassess this patient later in the clinic to see if there's any improvement or not. By and large, there would be. Now, I've written intravenous corticosteroids there as well. Now, there are some hospitals that I worked in where they, in kind of late stages, you give corticosteroids as well, and this is a way to reduce the fluids inside the pericardium. But the thing is, it's for those who have resistant pericarditis. But what you need to know at this stage is you need to know that first line treatment is aspirin or a non-steroidal anti-inflammatory plus colchicine. And of course, pericardiocentesis is when you have pericardial effusion, and emergency pericardiocentesis is when the patient has a cardiac tamponade. Now, a 40-year-old woman with prosthetic aortic valve develops persistent fever and positive blood cultures for Staphylococcus aureus. What is the most feared complication of this condition? Is it constricted pericarditis, cardiac tamponade, embolic stroke, or pericardial effusion? So somebody has not fallen for my tricks. It's going to be an embolic stroke. So cardiac tamponade is something to fear, okay? But in this particular case, what are you thinking about? So this patient has positive blood culture for Staphylococcus aureus, okay? Persistent fever, prosthetic aortic valve. This patient is coming in with infective endocarditis, all right? Now, what do we say? One of the biggest complications of an infective endocarditis be? It could be because of the platelet and fibrin deposition in the damaged area of the endocardium. We can have vegetation form, and in this particular patient, you can have a platelet plus fibrin plus bacterial organism, and it creates a infective vegetation, and this can branch on, this can embolize, and then go through the systemic circulation and go on to cause a stroke. So if it gets into the cerebral vasculature, depending on what side of the brain it's going to be, it can cause it can stop the blood flow. It can and cause ischemic changes, and therefore it can cause stroke. So there's two types of stroke. So you have ischemic stroke and you have hemorrhagic stroke. So in the case that I'm talking about with the emboli, it's ischemic stroke. So that emboli will stop blood flow completely to a particular area of the brain. Another one is hemorrhagic. Hemorrhagic is where you have the blood vessel just bursts and you have blood go everywhere inside the brain, not the cranium, the brain. And often that is life-ending. Okay, so I hope that makes sense. So thank you very much, guys, for joining this class. I hope it was very, very useful.